I'm not a doctor yet, so
No.
I can't tell you the knowledge.
No, of course.
But I'm saying like half up.
Yeah. So, can you explain in one sentence what was your hypothesis? What was your hypothesis for this research?
Just shortly.
Mm-hmm.
So we've got the plaque, and NIRS help us to check the chemical composition of the plaque. And the general idea is that the more lipids we've got in this plaque, the more remnants are getting detached and just flowing through the bloodstream. While if we've got more calcifications, some pieces of this plaque are not flowing away, but they are shifted aside. So that's the difference. And the point is that we've got some like distal protection, and New York checked it already, that if the LCDI is more than 600, there is some point to use this distal protection, but if it's not, there is no point. But still,
so there are two options. So you put in the stent, and then you actually have some plaque shift, that the lipids are actually moving beyond the stent and actually give some narrowing after the stent or before the stent. Yeah.
After not, this is very interesting. Yeah. But then it doesn't happen in a distal part, only in proximal.
No, I think that, but the general, of course, your data shows, but I think also in the clinical idea, you have also some plaque shift. Not only proximal, but also some distal sometimes.
And the point is that if we start using in the future NIRS and ISCOMS, we will know if we should use longer stents in every plaque, or we should use distal protection. That's the point of this study.
So it's very interesting. I was wondering, so 1/3 of the patients you included came with an acute coronary syndrome.
Yes.
It's a whole broad spectrum. Everybody probably knows, like acute coronary syndrome could be from unstable angina, from a stem line. Yes. So how was it distributed? What were these ACS patients? What did they have? Like unstable angina or a STEMI or
SMI.
Okay, so 1/3 of the patients came in with ST elevation myocardial infarction.
But we are not focused on them because a year ago, probably in Netherlands, there was another study which was focused only on these patients, and it's commonly known that the decrease in the plaque volume is greater in these patients. So we were just mainly focused on chemical composition.
But don't you think that might have some influence on your data if you take a completely stable plaque versus an unstable plaque?
But they were mainly with a higher LCDI, and in this project we're mainly focused on those which had lower LCDI. Like the whole study is very, very big. A year ago, I presented here
That's good. So next year, well, then you're not allowed anymore.
So a year ago, I showed the stented region, and then we were focused like on which one has greater LCDI, which has not. And this year, I just want to press that these ones with greater calcifications are just shifted aside.
Yeah, but still, I would say to lump these stable patients with the non-stable patient might give some. So for sensitivity analysis, you might
take it into consideration.
To look at the different groups.
Like
you have a question? Go ahead.
Why do you think that the lipids don't correlate with the plaque?
Why it doesn't correlate? Because in other normal study they chosen ceramides. This is a fraction of lipids, but normally we never check them in the patients. So we thought, okay, let's check lipids, which we usually check in every patient. So maybe there is some correlation, because there is correlation between lipid plasma levels and ISCOMS, and there is not between lipid plasma levels and NIRS. So that's interesting too.
Any other questions? Okay. Well, thank you very much
for
the
so
presentation. We'll move on with the presentation from Dr. Dong from the Department of Neurosurgery from China with the presentation about optimizing cerebrovascular endovascular procedures and resident training by personalized 3D printed models. The floor is yours.
Thank you.
You can just
Can I have a try?
click
I haven't presented my
I click it another time.
and then
And then yours.
Actually here.
Shoot whatever you want.
So hello everyone. My name is Meng Qidong. I come from Shantou Medical University from China. and it's a very great honor to give a presentation here and share my research with you. So the title of my research is Optimizing the Cerebral Endovascular Procedures and Resident Training via Personalized 3D Printed BAVM Models. Let's begin my presentation.
Otherwise, press the space bar on the keyboard. If you go to the keyboard. Yeah, does that work? Yeah.
So what is BAVM? You can see from the picture. So the BAVM is so this is a classical illustration of the BAVM. The artery connected directly with the veins without the capillary bag. So this is the meters of the AVM. In this part, there is a collection of vessels. We don't know exactly the structure inside it, but the blood pressure, the blood flow directly from the artery to the vein. So the high pressure transmitted directly from the artery to the vein. So in this part, it's very high pressure. It is very easily to lead to bleeding, and bleeding can cause hematoma and can cause very serious consequence. So the treatment is very important. There are 3 treatment options: microsurgery, radiosurgery, and endovascular embolization. I will talk a little about the endovascular embolization. We can insert a catheter, just a little tube from the aorta and then into the cerebral artery, and we come here, and these are the feeding artery of the BAVM. So we choose one, and then we choose one artery and we insert the catheter. For the embolization, we will inject some material, some special material, which we call onyx, some gel-like material, to make this part solidify. You just start something like solidify to stop the blood flow from the artery to the vein. So this is about the endovascular embolization. This is something about the BAVM. And about the 3D printing technology. Yeah, this is a technology that developed rapidly in the recent decades. Nowadays, it is used in the maxillofacial area and the orthopedic surgery. They use the CT or the MR imaging material to reconstruct the bone, the vessels in the computer, and then they print it out, and they can also design the surgery instrument in the computer. So this is a very useful technology nowadays. And what about in the cerebral vascular disease? So in the recent research, most of the research on the cerebral vascular disease focus on the aneurysm. This is the aneurysm, just like a bubble comes from the artery wall. So it's a very simple structure. So it is very simply you can very simple reconstruct it in the software. But what about the BAVM? It is a very complex structure. This is the meters, and if you are a young neurosurgeon, you can even you can't figure out which are the feeding arteries and where are the draining veins. Yeah, it's very complex. So my research is to how to apply the 3D printing technology into the use of the treatment of the BAVM. So that is my research. I use the Mimic software porting and to reconstruct the BAVM, and then I print it out, and using the printed model, I assess the vessel, the artery size, the artery diameter, and comparing it with the real artery diameter intraoperatively. And we also use the model, the printed BAVM model, for patient communication pre-surgically, and we also use it for the resident training. So this is the result. This is a picture shows the process of my reconstruction of the model in the computer. We reconstruct the scalp, the the cerebral artery and the vein separately, and then we combine them together, and then we print it out, and then we assess the size, the diameter. We comparing the diameter of the artery in the model and from the PSA imaging. So there are 97% agreement with average less than 2 milliliter variation. And also for the patient counseling with the BAVM model, we need less time for informed consent, and we get a higher degree of satisfaction with the use of BAVM model. And for the resident response to the model, 80% think it is useful as an educational tool for them to learn the BAVM structure, to learn something about the BAVM treatment, and 66% think it is helpful for them in the understanding of the BAVM structure. So here comes to our conclusion. The 3D BAVM model can be printed out with high accuracy, and it is helpful in the pre-operative patient counseling, and also helpful in the resident training. So what is the problems we met in the research? As you know, the structures inside the needles is very complex. There are still some small vessels. It's very difficult to reconstruct. This is what we can't do in nowadays. Secondly, is the time and the cost. Because of the complexity of the structure, it needs a lot of time for the reconstruction of the vascular structure. And the cost, if you want to print out a model with the skull, with the artery, and with the vein, you need almost 700 euro. And also now we get too few models. I think in the future we can bring out more models and to get further investigation in the clinical use. So in the future, I think nowadays now we are doing the research on this part, the brain AVM volume, because for the endovascular treatment, if you need to inject the onyx into the needles, you need to know how much volume of onyx you inject into it. If you can have the printed model, you can know it, you can measure exactly how much is the BAVM volume, and then you can decide how much you should use for this specific patient. So that is all my presentation. Thank you.
Thanks very much for your presentation. The paper is open for discussion. Are there any questions from the audience? Yes.
Thank you for your presentation. It was very good. I want to know if you had you assessed the complexity of AVMs in your patients, how complex they were, and which grade did they have? Thank you.
The grade?
Grade, yeah. Or did you assess the grade of AVMs?
To the patient, you mean I discussed with the patient grade or?
I want to know how. So okay, let's begin from the very beginning. You tested this model in the 7 patients, yeah? Right?
Yeah.
And you reconstructed these try to reconstruct the AVMs they have in 3D, yeah?
Yeah.
3D models.
Yeah.
How complex were those AVMs you observed in these patients, and did you put the grades to them? Because there are grading systems for AVMs, and I was curious, maybe you assessed the grade as well?
So it's probably more like an assessment of the complexity of the lesion. So you would say, like, is it also working if you have very complex lesions?
Yeah.
Were all the lesions the same, or do you have some background information about the patients in which you did it?
No. In fact, this is the very initial step of this research. I think in this step, the most important thing is how to reconstruct the structure of the BAVM. So now we don't check the background of the patient, we don't confirm the grade of the BAVM. We just want to figure out how to reconstruct this structure, because this is very hard task
So
for
you
us
work
right now.
out the procedure of reconstructing, yeah?
Yeah, it's very hard. So nowadays, why there is very research on the aneurysm, because it's very simply to reconstruct. It's just a bubble. But if you want to reconstruct such a BAVM structure, it need almost 2 or 3 weeks. Yeah. So that is the most of my time is spent on the how to learn the technique, how to reconstruct structure. But in the future, I can apply this technique into more clinical use.
So what do you feed the computer for reconstructing? Is that like an angiogram or?
How can I learn?
Yeah, what do you feed the computer to make the model? Yeah, what do you put in there? Is it the angiogram or
CDA.
do you like a CT scan or?
Yeah, CDA.
Okay, CDA. Yeah.
You can use the CDA or the DSA imaging.
Yeah.
For the DSA imaging, you can get more detailed information about the artery.
Yeah.
Because
Yeah.
if you use the CDA, it's not better than the DSA.
Okay.
Yeah, but now I use the CDA.
Yeah.
Yeah.
So if you, I think, perhaps we're all curious. So how's it going? So there is this patient coming in with this a malformation, and then somebody is approaching it. Who's like your sort of patient being approached? Are you okay that we make a 3D construct of your malformation, or is somebody designing that the patient is eligible for that, or?
You mean if I ask the patient
Or
if they want
yeah,
to print out their
Yeah.
before our there is very little models, but only 7. But for all of the patients we inform them.
Okay, and then you get the images, and then your 3 weeks of work with your computer to structure everything.
Because it is all done by myself.
Yeah.
So and I learned it by myself. So
Okay.
it takes a lot.
And do you think you can automate it, like to make it higher throughput?
Quicker.
Quicker.
Because from the beginning to until now, after practicing a lot, I think the speed is
Okay.
And you
But
can
still, it would be a week or 2.
you can know how to use the software more
Okay.
better.
And then you
Very
print it. And how much
perfect.
time does it take to print it?
What?
Printing?
I don't do that work.
No, but
After I
you send it somewhere.
I think
And how much time does that take?
about 6 hours,
6 hours.
6 to 8 hours.
So once you have it done, then okay. Interesting. Yeah.
Congratulations on your wonderful research.
Thank you very much.
I'm very curious about it. I also understand her concern. Like, how did you get the patients? Did you base it on like the existence of the diagnosis, or was it like did you choose a certain grade that you can? Because you said that there was an issue with smaller vessels, right? So did you choose it according to grade? Like because AVMs have a grading.
Yeah.
So did you like try to limit it, or was it like just if they have the diagnosis then you go like that?
In that, I think I have answered the question. So I don't choose the patient according to the grade, because now my research do not focus on the prognosis of the patient. I just use it for pre-surgical patient counseling and resident training. So I don't consider the grade of the AVM. I just ask them, I will use your imaging material, and then I will reconstruct it, and
So you base it on existence of the diagnosis. Like there is a diagnosis.
CDA.
Yes.
I use the CDA imaging.
Any other questions? Is there a follow-up that because you could think about the strategy that you give the neurosurgeon the 3D model, first you don't give it, and then you would say like the outcome of the patient would be better if they had the 3D model? Is that because now you looked at informed consent goes faster? Okay, that's it's not really blinded, I would say, but at least you get
the most important work of my research is focused on designing a simulation system for the young neurosurgeon. Yeah, if I can get a better behavior model, and just I have the picture. Sorry. Yeah. Because I have no time, so I don't show you this picture. But in this picture, in fact, this is for the simulation for the young neurosurgeon. Yeah, as you can see, this is the aneurysm, and the young neurosurgeon, they can practice how to apply the clips. Yeah. So in the future, I think if I can reconstruct, I can bring out the behavior model. I can also develop a simulation system. This is the most important.
Okay.
Instead of the for the patient.
No, understand.
Yeah, but it also indirectly it is we do that to the patient.
Sure, but you didn't plan a whole research structure yet.
Thank you.
No. Okay. Thank you very much for your presentation. So we'll move on with the presentation from Dr. Postema from Maastricht, I believe. And it's titled Targeting Coagulation Factor 10A Attenuates Myocardial Ischemia Reperfusion Injury in Mice.
Thank you very much. Let me see if I can the presentation works.
For this, I have live streaming on my YouTube.
Yes, thank you very much for the nice introduction. My name is Jelle Postema and I'm performing research at the Cardiovascular Research Institute in Maastricht here in the Netherlands. And mainly focusing on the role of coagulation in ischemia reperfusion injury of the heart, and I perform this in mice. So first of all, I have no conflicts of interest to declare. Myocardial infarction induces hypoxia of the myocardium, of course. And it's long thought that especially this ischemic time, it induces the damage of the myocardium. And so therefore the treatment nowadays is mainly focusing on shortening this ischemia time. But in the last couple of years, like in the last 10 years, we discovered that actually especially the reperfusion induces damage to the myocardium as well. And there are many studies done on this, and there are some studies which show that not clinically available anticoagulants can actually reduce this ischemia reperfusion injury. But of course the problem of these agents were that they're not clinically available. And the medicine we had available, the vitamin K antagonists, actually showed that they increase the ischemia reperfusion injury, but that's because of the vitamin K antagonists play a role in calcification as well, and thereby actually enhancing the inflammation. And coagulation factors itself are actually found to be regulators in inflammation, and this is mainly due to the activation of the so-called protease-activated receptors. These receptors are present on many cells involved in ischemia reperfusion injuries, such as endothelium, but also the cardiomyocytes. So it's not surprising that they might actually play a role in ischemia reperfusion as well. So how does it come that actually the reperfusion itself induces damage to the myocardium? This is a complicated picture, so I will not talk you completely through it, but when you see it during ischemia, you have a lower pH, which causes damage to the mitochondria. But especially during reperfusion, we get the production of the reactive oxygen species, which actually induce injury to the myocardium. So what we want is, of course, we want to have the ischemic time as short as possible, and that's something we do very well at the moment. I think we get patients with a myocardial infarction to the hospital as soon as possible and perform PCI. But the current treatment is not focusing on preventing for the reperfusion injury. So the aim of my study was to investigate if I can directly inhibit factor 10A with a new clinically available anticoagulant called rivaroxaban. Does that attenuate the myocardial ischemia reperfusion injury in mice? And therefore I used wild-type mice. They were 8 weeks old, and what we did, we divided them in two groups, in a placebo group and a treatment group, in which we treated them with rivaroxaban at point when the reperfusion started. And how we performed this was at day 0, so when they were 8 weeks old, we performed the surgery in which we put a ligation on the LAD, which is one of the main coronary branches of the heart. And we were actually able to perform this operation, but during operation you induce inflammation in which we don't want to influence our outcomes on the myocardium. So we were able to close the mice again and put these ropes of the ligand outside the mouse. So the mouse recovered for a week, and then after a week we induced the ischemia for 1 hour, and after 1 hour we were able to loosen the ligation, and we could see on the AKG from the mice that the ST elevations went down, which was a control for us that there was a proper reperfusion. And then we reperfusion for 24 hours, but also for 4 weeks. So we can look at the acute effects of the inhibiting factor 10A, but also the effects on the long term of the remodeling of the myocardium. And how we studied this was by taking out the heart after the reperfusion, and we could divide 3 sort of tissues, with staining with the Evans blue. Every viable tissue gets blue, and then followed by a TTC staining. And the TTC staining is within the area at risk, so the area that didn't get blood. There are 2 types of tissues. One tissue is already dead. It's the area of infarction, which is not viable, has no chance of recovering. But there's also a part which had a long hypoxic time, but actually had the chance to recover, and that's what gets red when you stain for TTC. What gets pale is actually the area of infarction. And this here you can see very well. So this whole part was hypoxic, but there's a red part which has the chance to recover, and a white part which is already dead. So with this, when you have the area of infarction within your area at risk, it's actually you can show how big the damage is of the myocardial infarction and reperfusion. And what we also looked at in the long term was the left ventricular ejection fraction, and that's actually a parameter for the function of the heart. So and that's depends on the remodeling of the heart, but it's important. But also we measure in persons like how well is this myocardium still functioning. And what we saw that after 24 hours of reperfusion, the area of infarction within the area at risk was significantly smaller in the group that received rivaroxaban. So we were actually able, in this tissue which was at risk, that there was more tissue that could recover compared to controls. And after 4 weeks, we stained the myocardium for fibrosis, which is the parameter for the remodeling. And we saw that when we treat them with rivaroxaban in the acute phase, after 4 weeks, there was less myocardial fibrosis, which indicate, again, if there's less tissue that's dead, there's less myocardial remodeling, but does this also influence the function of the heart? And that's what we saw with the left ventricular ejection fraction. And we saw that at baseline they were similar in both groups, but directly after reperfusion you already see a difference. However, at this time point it wasn't significant. However, after 4 weeks there was a significantly better left ventricular ejection fraction in the group that received rivaroxaban when you compare this with the controls. And there was a strong correlation between the myocardial fibrosis and the function of the heart. So this means that indeed the left ventricular ejection fraction is depending on the amount of fibrosis of the myocardium. So in conclusion, with in the acute phase adding rivaroxaban to the blood, we were able to reduce the ischemia reperfusion injury in mice, and this was associated with less fibrosis of the myocardium and also a better outcome of the left ventricular ejection fraction. So this is the first data. Of course, what I'm very interested in, and this is what's ongoing now, is that we actually give these mice rivaroxaban for 4 weeks. But first we have to know what the effects in the acute phase would be, and if there's an additional effect when you give these mice anticoagulants for a longer time. And of course, if we have these results, we would like to translate this to the clinics. However, it's hard. We're still thinking of a model in which the ethical committee would agree to, which we can study this in patients as well. But you can imagine the problem with this patient, normally they already get an antiplatelet therapy, and when you also add an anticoagulant to that, the ethical committee is not very happy with this. although the risks are already getting lower. So of course, we thank the team I'm working in. I'm very happy to receive any questions from the audience.
Thanks for a very clear presentation. Are there any questions from the audience? Yes,
How
go
did
ahead.
you induce the ischemia?
The ischemia is so on the LAD we put a ligand on it, and it's just a small rope like which we stitch with as well. And you put it around, but you don't tighten it fully. So you knot it, you leave it open, and then you close the mice again. But these ropes are still outside the body. And when we pull on the ropes, we can actually induce tightening of the ligation and thereby inducing this ischemia. And when you loosen it again, the rope gets loose, and then it causes the reperfusion.
Good question. Yeah. Any other questions? So interesting because like the direct oral anticoagulants we're now using quite commonly in patients with atrial fibrillation mostly or pulmonary embolism. So do you think it's specific for factor 10A, for example with rivaroxaban, or would you expect, so you already alluded about the vitamin K antagonist, you say like might have some effect on calcification. But what about the dabigatran, the direct thrombin inhibitor?
Yeah, it would be very interesting to look into because I think that thrombin as well as factor 10A have influenced this. But it's very hard because you have these protease activated receptors and you have 1 until 4, and it's very hard to elucidate whether this effect is mainly due to because we inhibit factor 10A, but of course when we inhibit 10A we also inhibit thrombin, and whether this is due to reduced activation of power 1, 2, 3 or 4. But first of all, it would be very interesting to just add dabigatran, and then we can elucidate a little bit the difference between 10A and 2A. And now we're working on specific knockouts of power 1, 2, 3, and 4 on the cardiomyocyte, which would give us more information which type of protease activated receptor is actually important for this. And this might also lead to maybe to new targets because the anticoagulants have some risks, but we know we can also specifically inhibit protease activated receptors, which might be much better than giving them anticoagulants.
Yeah, probably also related to atrial fibrillation because
Yeah.
I know your boss, I think is very interested in atrial fibrillation and anticoagulation, of course. So that's interesting.
Absolutely.
Any other questions? So I saw the difference. So you saw that there was a better ejection fraction in the animals treated with rivaroxaban, but there was not clear difference on fibrosis. Was there between the two groups, or
Yeah,
did I
there
miss
was
that?
some difference.
Because then you say like so there is.
Yeah.
So here,
Yes.
okay.
It's significant, although it's not huge. It's not as huge as the area of infarction within the area of risk.
So what do you measure here? Do you measure here also this part? So is it infarct size or both? Or is it only in the non-infarcted area to measure fibrosis?
No, what we measure is the fibrosis of the whole left ventricular.
Yeah.
So that's the whole left ventricular was infarcted and also was reperfused. And then we measure that showing that in blue is actually the fibrosis and in red is the healthy tissue. And I measure it in the whole left ventricular, not the right.
No. So here this is like actually the fibrotic, the scar actually you have, but there is also fibrosis here in the non-infarcted area, of course, because of hypertrophy, etc. So there might be a way to show, because this is the combination of, on one hand, the infarct size, of course, and on the other hand, also perhaps increase or decrease fibrosis in the non-infarcted area. So you might also consider to splitting it up.
Yeah.
So on one hand, infarct size, and on the other hand, like non-infarcted fibrosis. But
it would be very interesting. Only the problem is with these sections is in the other sections you see very clear the tissue that was infarcted, and but in this section it's hard to divide which tissue exactly was ischemic and which tissue not.
And mechanism, do you think about, because it's always nice to show that there might be, because now you just give a treatment, 10 versus 10 animals, I would say the evidence is not that strong yet. It would be nice to show that there is a dose response perhaps, so low doses of rivaroxaban give less effect than higher doses, for example, and to see if whether you have how it works, what's the mechanism, because if you can show the mechanism, then you make stronger your point.
Yeah, absolutely, and that's something we're gonna look into the next couple of years probably, But first we wanted to show if there was an effect or not, and now we're looking at all the mechanisms through which the coagulation factors might influence this. Because it could be the cardiomyocyte itself, it could also be working on the endothelium, which the leukocytes cannot enter the myocardium because endothelium is less activated or something. But it's absolutely something we're going to do, and that's something we're doing now. After this, we freeze the heart, and then we can actually perform more looking into the RNAs and the more signal transduction.
Which also a hot topic in industry.
Yeah, absolutely. That's what we do best.
Perfect. So you're gonna continue with the PhD in this?
Yeah, absolutely.
Okay, well, congratulations.
Thank
Thank you
you.
for your presentation.
Thank you very much.
The next presentation will be by Dr. Sakti from Indonesia. Extract ethanol on red brain. Well, it's I think a very timely topic. The effect of ethanol on the brain's last day today. So I'm really looking forward to your presentation.
Okay, thank you. Good afternoon. Yes. Let me introduce myself. My name is Faisal. I come from Indonesia. I would like to present an extraction of black sugarcane reducing red brain ischemia. So this is my content. I will explain background and conclusion. And as we know that soup has very dangerous diseases in the world and also in Indonesia. And the first one in North Sulawesi, South Korea, and the second highest prevalent in Yogyakarta. Okay, that is my own city. And the complication of the stroke is become paralyzed 15 until 30%. So described with stroke is very dangerous. And in our society in Indonesia, they believe that during of the decoction of the sugarcane is plant for making sugar, it can prevent many diseases, including stroke. But it's just an empirical study. So in my research will prove the effect of neuroprotective effect of the black sugarcane. And the literature, black sugarcane contain polycosanol, main compound in sugarcane, and the previous research just used polycosanol, but not from sugarcane to reduce the ischemia, and also polycosanol plus aspirin in the patient of ischemic stroke. So this is the taxonomy of the sugarcane. I use the black one, the variety of Saccharum officinarum, because there is no derivation, but more black one is more content of polycosanol or an other antioxidant. And this is the content of the sugarcane. Polycosanol is actually the long chain of the alcohol, and the main compound is octacosanol. It can be antiplatelet, so it can prevent stroke, and so the therapy of the stroke in the previous study. And also there are so many antioxidants, phenolic, catechin, quercetin, as anti-inflammation and anti-apoptosis. And this is the pathway of the ischemic condition in the brain. So we'll decrease the ATP production because it will making damage in the mitochondria, and will increasing the activation of cyclooxygenase, PKC, and will increase many hydrogen peroxide and increasing the lipid peroxidation and leading to inflammation and also the apoptosis. So the black sugarcane can prevent those activation. This is the framework of the theory, and we hope with the black sugarcane can reduce the lipid peroxide and will decreasing the ischemic area in the brain. And this is a concept in my hypothesis. Extract ethanol of black sugarcane, or EBS, and reduce ischemic area in the right brain. And this is my method. I use quasi-experimental with post-test group design, Krishnaphagicus, 5 rats each group, and the first group is treated group, and second is non-treated, and the third is sham group. And I use performing for the ischemic area in the brain with the bilateral carotid communist arterial occlusion, or BCCAO, to making the ischemic brain. So I will look directly to the brain of the rats of the ischemic area. Okay, for the process, in the first week I making acclimatization for the animals, and then in the second week I did the treat. I give the EBS for 40 gram per kilogram per day to the mice, only for the first group. And then after that, in the third week or the 15th day, I doing the ligation with BCCAO, bilateral carotid common arterial occlusion. And after that, I'm making euthanasia with transcardiac perfusion to taking the brain, and I use RTTC for the staining. And the last is analyzing with the ImageG software to measure the ischemic area in the brain, and also statistically with SPSS to know the significance. And this is I would like to share about BCCEO, bilateral carotid common arterial occlusion. So I make an incision in the neck of the rats. After that, I make a dissection to looking for the CCA, carotid common artery. So I make ligation with the silk bilaterally for 20 minutes. 20 minutes. After that, unbound the silk and making reperfusion for 2 hours. Yeah, we hope can make a ischemic area in the rat's brain. And this is the result. Yeah, this is very good. And we know that in the second group, without treating with EBS, the ischemic area is the highest one than the other groups. And the first group with treated and the control negative, there's no difference significance. And this is the p value is so significant with the others. And with the post hoc between first group and the third group, there's no difference. So it can conclude that EBS can be the preventing agent of ischemic area. And this is my discussion. This is soluble dye that can bind of NAD in the mitochondria. So in the ischemic brain, there is a damaged mitochondria, and DDC will not bind in the ischemic brain. So we will look that the red one is the healthy. The red one is the healthy tissue, and the white one is the ischemic condition. And this is the second group with the highest ischemic. We'll count pale, then the first group and the third group. So, and for the discussion, our method for BCCAO is supporting the other research with 20 minutes for BCCAO and 2 hours for reperfusion, and the others using the different time for BCCAO for 30 minutes and reperfusion for 1 hour, and also for the dose of polycosanol we are also supporting, because the other using 400 milligram per kilogram of polycosanol. And here's the conclusion. Extraction of black sugar can reduce ischemic area and red swing. Thank you.
Thank you for your presentation. The paper is open for discussion. Yes, a question.
Do you have problems with the TTC? Because I don't see clearly the sternum and cortex in the figures. I don't see, like you showed before, and it's very white, and in your results it's not so clear. Do you have any problems with this sternum? I don't see
Perhaps you can show the picture again.
in the results. When you see another papers, you see because you see that the stroke is in sternum and cortex, and I don't see. I see different color, but when you see in another paper, you see totally white, and here is more clear. For the reason I asked you if you have any problem with that.
Yeah, actually, we should have this microscope to make it more clear with the ImageG software. It's just macroscopic in the ischemic area. For example, this one, so sensitive. Yeah, and the weight one here and here, but we can see clearly in the microscope. Microscope with image sensor.
Because if you have like in the previous slides, you had one typical area that is totally white. For example, you say that you saw that in Australia because you did a lot of slides. But for example, if this is anterior and I don't see clearly the sternum affected, maybe the cortex a little, but the sternum is not so clear.
Yeah.
And you did some neurological score to be sure that was an ischemia. Yeah, you did.
Yeah, actually, I'm making for the all the measurement and making the mean of the average or the average the total ischemia from different side of the incision of the brain. So making total with it just for the example, and I can measure clearly in the microscope.
And you did a neurological score. You had a punctuation.
No.
No. Okay.
There was another question there.
Yeah, thank you for your presentation. It was good. My question, I have a few questions actually. First one is, so you didn't perform the histological examination because it is, you cannot distinguish, the core ischemic area, for example, and penumbra ischemic area, and it is a very interesting topic, and everybody. All the research is centered about the reduction of this penumbra area, and so you measured the global ischemic area, yeah?
Right.
And are you interested in examining also histologically what happened there and how the extract can influence also the penumbra?
Okay, thank you for the invitation. It's my pleasure. Yeah, actually, I have done for my research, another research. I use also the histologically, but this is for global ischemia, and for histological we can focusing in the part. For example, my research in the prefrontal cortex. So I just focus in the prefrontal cortex here, and I see from the microscope histologically, and I can measure from the neuron cell, the dead neuron cell. I can count of the neuron cell, how many are there still living, and compare with the control and the positive one. That is very interesting. But I'm so sorry I don't have prepared yet the picture. Maybe we can talk.
I might have missed this, but how much was the concentration? How much of the extract did you administer to the mice?
Yeah, for the extract, actually, I considered using ISCOMS protocol. In ISCOMS protocol, state that the polycosanol that can use for the animal model is 400 milligram per kilogram per day. It's polycosanol specific, and this is my limitation because I don't use polycosanol exactly. I just use the extract of the sugarcane, but there has known that in 100 gram of the pale of the sugarcane, it's contain 200 milligram of polycosanol. So I can measure that I just need 40 gram per kilogram per day of that extract. Yes.
And the last question then, how much of this that it's extract do the Indonesian people use? How much they take in when they're ill and they wanted to treat themselves? Your statement for this experiment was actually that Indonesian people use this extract to treat themselves, and I wonder how much they take.
Yeah. Actually, Indonesian people just use a drink. You know that sugarcane, plain sugarcane, we can press. You can drink. Just making drink as
so they do not measure.
Perhaps the question is, how does that relate to the concentrations you're using here? Is it like 10-fold or 100-fold lower, or?
Yeah, based on ISCOMS protocol, we can use 100 milligram of the sugarcane. Because it contains 200 milligram of oligosanol as on oxygen. Yeah, but yeah, we are associated just drink.
Are there any other questions? So I was somewhat surprised that you can get. Can you go back to the results on the infarct size or? So it's 2.8 and 2.4. So what's the difference between this is the sham group?
Yes, the same.
So why do you get infarcts at the sham group?
Yeah, actually, not infarct.
What is it then? What does it mean? This 2.4.
2.4.
Yeah. What does it mean here? 9.4.
This is the. Actually, we just measure the weight one. Maybe this is one of our bias maybe, but yeah, the weight one we still the measure the infarct one. Yeah, maybe this has.
But it's a sham animal, so it shouldn't have an infarct, should it?
Yeah.
But you get an infarct.
Yeah.
Oh.
Maybe.
Okay. So it's not a perfect experiment, I would say.
Yeah. There is maybe another hypoxia one because the condition can.
Okay.
The condition is not good one.
Okay. So even the sham animals get an infarct. Okay. Thank you.
Okay.
Let's move on to the next presentation. So the next presenter will be Dr. Torrejon from Mexico. At least I thought so. Did I spell it so badly?
Okay.
Wow. And
Whoa, that's a lot.
From China?
No, we haven't got his presentation, so he's.
Or probably then we're done here.
Yeah.
I don't know which one.
Okay.
No, we have to.
Maybe.
Okay,
can
yeah,
add
so then there will be a winner. So it's good for the presenters that two just didn't show up.
Email.
I think we'll come back to this in a minute or
I send it to
so.
you. Yeah.
Okay, and you stay
Maybe
here?
you can choose.
Well,
Okay.
they can
Which
stay here
one?
and we'll
Okay.
be back in 5 minutes.
Oh, okay. Well, now we'll be back. Okay, perfect.
Tung Linh.
I didn't even.
Let's make sure. Oh yeah. Faisal. Sakti. K. K. D. T. I. Hold on a sec.
Oh yeah.
Your study too.
Thanks. How about your presentation?
Yeah, it was fine.
Oh yeah. The oral or poster?
Huh?
Oral or poster?
Yeah, the poster.
Poster. Yeah. Where are you from? Which country?
Philippines.
Are you one group with Phil?
Ah, yes, yes.
Wow, you got the win.
Thank you.
Okay, congratulations.
You have good research.
Thank you.
Yeah, I hope that you can do more of that, like next level.
Yeah.
Yeah,
In the
hoping for
in
you.
the future. Yeah.
Yes. Sugar cane.